in a nutshell, bear with me on this, when you're diagnosed with a GIST, they look at the size of it, where it is, how quickly it grows. From that, they decide how you're going to be treated and with what drug. First port of call is to remove it. If they can't remove it, they need to reduce it. They'll look at which drug is best to do that. Bear with me. They then look at what to do with you further treatment-wise, whether it's all been removed or it's not all been removed, and that is based on, again, where it was, how big it was, and how quickly it multiplies. Is that pretty much in a nutshell?
Yes.
I know it's more complicated, but...
Yeah, the only thing that you haven't mentioned, maybe I haven't mentioned, is that when you are diagnosed with GIST that is inoperable at the first instance because it's quite big, sometimes on the, the histopathology specimen, we won't have the number of mitosis. So we know for a fact the dimension, but we don't know the number of mitosis. And that won't guide our treatment, because if the tumor is big, if the tumor is not amendable for first-line surgery, we'll go with neoadjuvant imatinib.
Yeah, so if it's too big to operate on, drugs are there hopefully to be able to reduce the size of it to make it operable with a bit of luck. So when I said at the start that mine was 7 centimeters in size in my stomach, 63 mitoses, that put it in the high category, which is why I had to have adjuvant treatment. And I always said, because it's not come back for me, touch wood, that with adjuvant treatment, you don't actually know whether it's working or not. Because if I didn't have it, would it have come back? We don't know. It might still come back. I've been off imatinib now for 10 years and it's not come back. Is that just me? Or is that because the adjuvant treatment worked to keep it in abeyance for till now? We just don't know. So that's why you do all these trials and you work out what the best is based on looking at a number of people in that setting. So this is why we have trials. This is why we look at I suppose the average way of doing it based on the best outcomes, but it's not the same for everybody. So, and that's something important to remember.
Yeah, and also important to know and remember is that nowadays the role of ctDNA is more and more present in different settings. So they are trying to see if we can predict the risk of relapse based on ctDNA, for example, for a patient who had 3 years of adjuvant imatinib, but so far as I'm aware, there has been no clear data to support like ctDNA, for example, post-adjuvant imatinib. But I think there will be a role for this in the future.
So you talked about getting ripretinib accepted as a treatment through the NHS and ripretinib. So the way that works, so back in 2014, imatinib, which is the first line treatment, which many of you may be on now, they were looking at that point of whether to use it in the adjuvant setting through what they call a single technology appraisal. So I went as the patient representative for GIST cancer to a room in Manchester, actually in the NICE headquarters in Manchester. I sat in this room and it was a long table with a chairman at one end, myself, Ian Judson, who is one of the gurus of GIST, and the then chair lady of GIST Cancer UK. Our role was to give the patient's view as to what we thought about imatinib being used in the adjuvant setting to try and help people that had their tumours removed, but there was a high chance of it coming back. On the other side of the table, there were at least 15 health economists. They did their talk first, each of them. So for probably 2.5 hours, I sat listening to basically health economists working out the cost-benefit analysis of my life. So the chairman, when they finished, said, "Right, do we have any comments from the patient perspective?" and invited me to say something. And I said that. I said, "Well, I'm really pleased that you've finished talking about the cost-benefit analysis of me and my life." He stopped the meeting and said, I've never heard that said before. He said, I want to just stop the meeting now. I'd like to apologise to you. And I think I've been told that since then, they now put much more focus on the patient rather than what it's costing. So, and then they approved imatinib as being used and being able to be being able to be prescribed by people, you know, in the oncology sector to allow it to be used in the adjuvant setting. And I believe now they look at all nice technology appraisals and give, rather than 10% to patients, they give 30% or more of their input to it. So it's tilted the balance, let's say, so that, you know, our roles as patient organisations will help much more now than it ever did. And we are now becoming involved in the nice technology appraisal for ripretinib, which is coming up very soon. So that's one of the things we do on your behalf, you know, in the background, and it's really, really important because some of you in this room would benefit greatly from that being able to be used by oncologists. So, right, I've spoken enough. Questions? Yeah. Use the microphone if you don't mind.
Yeah. I'm the carer, John. I'm the carer, John. This is my wife, Christine, who's got GIST cancer. My question is this. Sorry, is that better? Yeah. My question is this. My late sister had breast cancer, BRCA1, okay? And my late brother and myself had to be tested in case it had gone in the bloodline. Also, her 3 children were tested. We were all negative. So my question is this. For GIST cancer, do my does my son and daughter need to be tested? Does my 5 grandchildren need to be tested down the bloodline for GIST cancer?
And if so, how?
So you've mentioned BRCA mutation. Is that correct? BRCA. Yeah. So in terms of GIST, I can BRCA1. Yeah. So in terms of GIST, as far as I'm aware, there's no like direct correlation of BRCA with GIST. So
I think what he's saying is that he was giving the example of BRCA being tested for them, but now that his wife has had GIST, following that sort of similar process, should his siblings and children, grandchildren need to be tested?
In terms of your wife's GIST diagnosis, was she diagnosed with what type of mutation? Do you know the mutation or the molecular panel of?
So exon 11 standard.
Exon 11. Okay. So regorafenib. Okay. Yeah. Yeah. I wouldn't necessarily recommend testing in this setting. So I don't think there's like a risk for your family to develop a GIST based on the fact that you've developed this KIT exon 11 and this is like a somatic mutation that triggered your cancer, even though there is like a strong background of like BRCA in the family. So that would be my recommendation. In terms of regorafenib, what I haven't said, and it's important for you guys to know, is that at any point, if the disease is not responding to regorafenib, there are other TKI options that can be accessed via compassionate use. And we've started to do that as well. So compassionate use means that the drug is approved worldwide, United States or Europe. It has shown some efficacy. For example, last year at ESMO, lenvatinib showed efficacy in the subset of patients that have progressed on 3rd lines of treatment. So if you progress at any point, you need to know there's like compassionate use access, cabozantinib, maybe lenvatinib as well.
Yeah, so siblings or children have never been tested if they, Christine's case, she's got GIST cancer.
So for exon 11, yeah. Yes. I think for exon 11, I think as was said earlier, the chances are that it's not a hereditary mutation that's driving it. However, there are GIST cancers that are driven by hereditary mutations. So I have SDH deficient GIST. Mine was driven by an SDHA mutation, which has been found to be a hereditary mutation. So my brother was tested, my children have been tested, his children have been tested. So it's done through genetic testing. No. But that doesn't necessarily mean that they're going to get GIST. All it means is that they have a higher probability or predilection to getting GIST or paragangliomas or other things that are associated with an SDH mutation. So if you get your biopsy, and this is why it's really, really important, I think, for everybody who has GIST to get some form of mutation testing done, just so you are aware of what it is the mutation is that was driving the GIST. If you know that, then the MDT should, if it's SDH deficient, or they find that it's like an SDH A or B mutation, they should involve a geneticist and you get genetic testing of the family. So they know who's likely. And then they're put on a screening program.
So for exon 11, because you need to have in your mind how the GIST appeared. If it's a sporadic case in the family, what's the age of onset of GIST? Because usually for these genetic related GISTs, you will see the GIST at a young age, usually for children, young adolescents, even young adults, and it will be multifocal in nature, and it tends to have like a slow progression rate. So based on the characteristic that you've mentioned, at this stage, I wouldn't necessarily recommend a genetic testing.
Okay, thank you. Got another question here.
Hello. Donna, I need to find you later, wherever you are. Donna. I don't know where she is. Anyway, so I'm Vicky Rockingham. Hi, Donna. I'm SDH deficient. I've been living with this for many years, so I am no longer on any medication. And also, interestingly, my youngest son has just been tested and has the mutation. And that was through the Manchester Genetics Centre, and he will now be monitored, so that's brilliant. The other one hasn't been tested yet. But my question is about the INSIGHT trial and the other trials. So the INSIGHT trial, has that been paused or stopped for safety reasons, or is it because they've got enough people for phase 1 and so we need to wait for phase 2?
As far as I'm aware, INSIGHT is still recruiting.
Right, okay. What about the strategist trial, the IDRX42?
That's a phase 1 trial, and that's still open for recruitment. So everything that I've included here is still active and open for recruitment.
Okay, so if we are interested in those, is it through our oncologists, such as yourself, that we push to try and find out whether we can get onto those trials or whether we would even be suitable for those trials?
Yes, so that can be discussed with us, and then we'll see the role of the trials in that setting. And yes, yeah.
And if for some reason you're not put forward, are you ever told why that is?
Usually patients should be aware of the reason why they weren't included, why we won't consider this trial. So you need to have like a direct conversation with the patients, because in the end, it's their disease, and from my end, I try to help as much as I can with your disease. So even if basically we will say like, bad news, you won't be eligible, I need to give you the reason why you won't be eligible for it.
Yeah, and that's often down to mutation, isn't it, etc. So
yes.
Yeah. Okay.
And there's like a lot of inclusion-exclusion criteria.
Yeah. I mean, if you're eligible,
usually exclusion is
edible. If you're eligible, you're eligible. So, you know, be put forward. Any other questions?
Hi. I had a tumour removed at 22, 10 centimetres in my small bowel. It had perforated. I'm coming to the end of the 3 years for the imatinib, and I've been advised that it may end then, or it may be lifelong. Who makes that decision, or how is that decision made?
So that's a good question. So it depends based on other characteristics of your tumor.
Can I just repeat the question, because it wasn't heard by some? So you're basically asking that had a tumour removed, it perforated, it's been on it for 3 years, and doesn't know whether or not it will continue after that on imatinib or not, exactly. And wants to know what the criteria are to. Yeah. Yeah, because it's high risk. Does that therefore mean it should be lifelong, or what? Who makes that decision? Why and how?
Yeah. So that decision is so you would be a good candidate for the MDT to discuss the role of imatinib after 3 years. What I can tell you is if the disease was localized, even though it was big and the tumor was ruptured, if there were no other sites or no other suspicious lesions all over, like abdomen, peritoneum, and so on, our recommendation would be to stop imatinib after 3 years and continue with close surveillance, and then at any point, if it will come back, to continue on indefinite imatinib. Welcome.
Any further questions? Right.
Are there any drug therapies other than those that are TKIs?
In GIST? So in GIST, the most effective ones are the TKIs, because the rationale would be that with the TKI you will block that abnormal kinase that's triggering, and it's still on like mode on, and it's proliferating signaling and so on. There's that interesting trial that I've mentioned with on the SDH deficient population in Korea. And they have another one. So one is with temozolomide to see if there's a role of temozolomide of chemotherapy in this setting. And another one would be the role of oral paclitaxel, which is another chemotherapy drug. So there are 2 interesting trials that won't imply TKIs. Also, what I can tell you that based on previous data, the response rates with chemotherapy in GIST populations are very low. So there's no point putting you through this burden of chemotherapy when we know for a fact it's not going to help. So at the present, there is no other option than tyrosine kinase inhibitors in GIST.
We have to remember that, and I was told this
exactly.
when I was diagnosed, if you're going to get a cancer, a GIST isn't a bad one to get. I mean, they're all bad, but do you know what I mean? Because there are treatments, targeted treatments. So 2 years after I was diagnosed, my wife had breast cancer, so I had to see her go through full chemotherapy, lost all her hair and all the other side effects that you get with it. Yes, there are side effects with the treatments that we have to endure, but they're nowhere near as bad, in the main, to full chemotherapy. So, you know, it's not a good thing to have to go onto these drugs, but at least they are targeted, and they do, when they work, they do work really well. So that's the positive. I always try to be as positive as I can on it. I have a question here.
Yeah, thank you very much. Our daughter is currently planning to have a full gastrectomy in the next 2 months because of a reoccurrence in GIST in her stomach after 20 years. She's SDHA deficient, wild type, and Carney's triad. Part of the reason why she's planning to undertake the gastrectomy is chances of it not reoccurring anywhere else in her gastric system. Noting on your presentation, you did put some statistics on that, but most of the presentation was associated with GIST, which was drug tolerant, as in affected by drugs. Obviously, SDH at this moment in time isn't. Where as parents, my wife's a carrier for that SDH deficient gene. She's under surveillance, and we're all obviously conscious of our daughter, who's 29 now, having had pediatric GIST since the age of 8, what her prognosis is for the rest of her life on a reoccurrence.
That's a good question. I'm not quite sure about the figures because you said prophylactic surgery. That will reduce, but that won't guarantee that the disease won't come back at any other site. And it's difficult to predict how she will, if the disease will be present, how it will behave, where it will behave. If it will be localized, then she might be amenable for another surgery. Usually the pattern is that a genetic GIST is not that aggressive as compared to like a somatic triggered GIST. So that's what I can tell you in terms of prognostics and figures. I think a genetician would be more advisable to tell you exact figures if they have figures.
Okay, I have another question here. I've been told you've got to hold it like this.
Hi, I just want to know, do you routinely tell your patients what mutation they've got and what their meiotic rate is?
I personally tend to tell them, even though I don't know how many will understand, but I try to make them understand because it's important part of their diagnosis. Sometimes what happens is there might be a discrepancy from the moment. So they had surgery, they will come to us, they will be for adjuvant imatinib based on tumor characteristics, but we won't have the KIT mutation yet. We will automatically believe that she will be KIT mutant, which is like the most common. So we might start for some patients imatinib earlier because we don't want to leave like a long period of time. But usually, we will have everything gathered, and based on that, we'll discuss. Look, you have this exon 12. Which is sensitive to imatinib, you should respond. That's like the predictability of response and so on. But I cannot guarantee because there might be subset of patients, even though they have the sensitive mutations, they might not react well or respond. But I tend, and I would suggest everyone to tell the patient exactly what they have.
It's only because we've been told my husband's got a slow growing GIST, and it's been there years. So I'm assuming the meiotic rate's low. Is that an assumption you can make, or is that I'm just making that up? Do you know what I'm saying?
Yes. So it should be. So it should be like a low mitotic rate, right. Or should be like a low size. So
it's a large size, but
or
years. So that's the assumption I've made, that his meiotic rate must be low.
Yes, otherwise,
yes.
If you have big size, big mitotic rate,
exactly.
you would need treatment.
Right, yeah, okay, thank you.
But nevertheless, it should still be biopsied if it can be, and mitotic rate actually determined. Has he had a biopsy? Well, in that case, they probably have done it, they just haven't told you. Yeah. Another question here?
Yeah, it's quite similar to the one that lady's just asked. I was diagnosed with a GIST in 2023, April 2023, as a result of having a CT staging scan for uterine cancer. So I had an endoscopy where some biopsy samples were taken, and I was also diagnosed with hiatus hernia. Everything was then put on hold regarding my stomach because I had a total hysterectomy, and unfortunately the cancer, although it was stage 1, was high grade. It was a carcinoma, so I had to have 6 months of chemo and then radiotherapy. Last year I finished my radiotherapy in February, and in March I saw the doctor that I'd seen the year before at Warrington General. And he, on both occasions, gave me the impression, actually said, didn't he, because my husband was there, that I'd be operated on for the GIST. It is 2.1 centimetres, but I don't know the depth of it because all I've had is an endoscopy, and I did have biopsy samples taken. But I found it incredibly difficult to wait 12 months for another CT scan because the MDT said that it hadn't grown through the year that I'd had the hysterectomy and then the treatment for it. But I found out yesterday that it's 3 centimetres from my esophagus, and I know it's 2.1 centimetres circumference. Don't know how deep it is, and my symptoms of acid reflux and what have you has got a lot worse since November. I'm having another CT scan in April. I'm still under the care of the oncology team at Clatterbridge for my uterine cancer. So I never know whether symptoms I'm getting are to do with the treatment I've had for the cancer or whether it's to do with the GIST. And I don't know the mitotic rate. I don't know what it is, what form of GIST it is or anything. I'm just sort of, having been told to wait 12 months, I did seek advice from Macmillan, and I did speak to a lady called Sharon from GIST when I joined the forum. And I just feel that I've just got no information other than from GIST Cancer UK, really. That's where I've learned everything. And I don't know what to ask, really, and push for, because I was told yesterday by the upper GI nurse that the MDT were specialists and they knew what they were doing. And as I say, I've just been given bits in dribs and drabs. Obviously, I've been recovering over the last 18 months from the cancer treatment. Hysterectomy was nothing in comparison with that. So now I'm, should I push now for an ultrasound endoscopy, which is what I was supposed to have?
Yes, so I understand your concern. What I can tell you first is that in terms of putting together GIST and a high-grade uterine carcinoma, or which you had, the high-grade carcinoma is way more aggressive. So usually we had these patients that needed on hold, to be put on hold with their treatment because they had a subsequent carcinoma, like a colorectal, for example, and that's a safe thing to do. Now, because you've said you've developed worsening symptoms, I would be concerned, to be honest, and I would try to explore that, and if the reason why you are struggling is because the ongoing growth of your tumor, then the MDT should discuss the role of a more radical approach and resection, because I see it can be quite challenging, and for you it's quite a burden to live with.
It comes back, if my scan comes back, my experience I'm having, and it still hasn't changed on the surface. I don't know what to do.
Yeah, so right, the complication here is that you feel as if the GIST element of your cancer is being left to one side a little bit and isn't being followed through. So yeah. So you don't want the GIST to be forgotten almost, or not be followed through in the proper way. Yeah. So where are you being treated? Right. Okay. So you get a second opinion from somebody, so we can help. Come and talk to us afterwards. I think that's probably best. So you've got quite a unique situation there. So come and talk to us in a minute, and
also you can raise the questions to your parent team, so the team that's looking you after in terms of GIST.
We'll talk about it afterwards. All right. So, okay. I think we'll end this session for a moment. I noticed whilst I was wandering around that quite a few of you have written questions down, and some have pinned them on the board. There's a couple of other boards over here. If you can continue to do that, are we having a break now? 12 o'clock?
There is coffee, so people can go and get...
Right, okay. So there's coffee outside and probably some Danishes. So, right, so yeah, we're doing a quick bit about GIST Cancer UK, but take this opportunity to pin some questions on there, and then we'll try and collate them into themes, and then I'll ask those questions in a minute. So thank you very much for your...